Hello everyone, and welcome to Tick-borne diseases, a regionally relevant review for Southeastern practitioners. My name is Joseph Granado, and I have a bachelor's in science and animal science from the University of Tennessee. This continuing medical education enduring material serves as my MPH capstone project for Des Moines University. It is approved for CME credit from the Iowa Medical Society and Des Moines University. I hope you enjoy the presentation. Relevant to the content of this presentation, I have nothing of importance to disclose. During the CME, I will discuss tick biology and tick species present in Tennessee. This presentation will review the risk factors and prevention methods associated with these disease vectors. Focus will be given to the identification of the signs and symptoms associated with tick-borne diseases, while recognition will be given to the appropriate diagnostic and confirmatory testing protocols. Finally, I will examine the industry standards regarding the treatment of tick-borne diseases. Okay, let's get started with some tick biology. This section will provide a brief overview of tick species and their life cycle, but more importantly, it will serve as an introduction to the tick species relevant to public health and healthcare providers in Tennessee. Ticks belong to the taxonomic group Acari, and as most of you have probably encountered personally or through a family member, friend, or pet, they are ectoparasites that feed on a variety of vertebrates. In terms of the number of infectious diseases transmitted, ticks are second only to our summertime nemesis, the mosquito. There are two different types of ticks. Hard ticks attach for longer periods of time and are most relevant to this discussion around tick-borne diseases. While over 80 tick species have been documented in the United States, only 17 of these are known to inhabit Tennessee, and less than 10 of them ever bite humans. The displayed pie chart demonstrates the abundance of human-biting ticks in Tennessee. With that being said, there are over 30 tick-borne diseases of relevance to the One Health ideology that as healthcare providers, physicians, nurses, and veterinarians, etc., we are all in this together. A tick's life begins as one of 3,000 to 6,000 eggs. Once eggs hatch into larvae, they immediately leave the protection of the leaf litter or grassy area in which they were born to seek out their first blood meal. Once the larva or seed tick finds a host, it will attach and feed. It is during this initial and each subsequent feeding that the vast majority of ticks can acquire and become infected with disease pathogens. If disease prevalence is minimal among host populations, the likelihood of a tick becoming infected will also be minimal. After feeding, the tick will fall off the host, molt into the next stage, and begin looking for a new host on which to feed. With each feeding, they can acquire and/or transmit pathogens. As humans, we are acceptable hosts at any stage of the tick's life cycle. A tick's life can span from 6 weeks to 3 years, depending on the species and host availability. If a host is unavailable for a period of time, ticks will sometimes overwinter, extending their lifespan. Please note that the life cycle and preferred hosts shown are for one tick species and will vary depending on species and geographic location. Since a tick's existence depends on their next blood meal, they are extremely devoted to finding their next host. Ticks do so passively by holding on to the undergrowth along well-used wildlife trails and waiting for a host to brush by them. When the opportunity presents itself, they do not jump but quickly climb onto the host. This passive behavior, called questing, can be seen in the top picture shown here. Ticks will also actively seek out a host if they are stimulated by carbon dioxide, body heat, or vibrations. Once a tick locates a host and climbs aboard, it will use its specialized mouth, seen in the picture at the bottom, to secure itself and begin feeding. One of these highly efficient anatomical features is called a chloricera, which is used to cut through the skin. Upon entry of the skin, the clericera includes denticles or barbs that help maintain attachment. Once firmly attached, ticks use their hypodermic, needle-like mouth, called a hypostome, to feed on the host blood. Since a complete blood meal takes hours, ticks also have some very specialized enzymes in their saliva. These enzymes promote inconspicuous attachment and blood transfer. As previously discussed, ticks acquire disease pathogens by feeding on infected animals. The worst case scenario occurs when a tick acquires a pathogen from a host during its first blood meal. Since the disease pathogen remains in the tick throughout the duration of its life, it will have multiple feeding opportunities to transmit the pathogen to other hosts. If infected at the larval stage, the same tick could acquire additional pathogens in subsequent feedings. However, since not all animals are carriers of an organism, it is possible for a tick to feed on multiple hosts and live its entire life without becoming inoculated with a pathogen. This would be the best case scenario. The good news is that transmission takes several hours depending on the tick species and pathogen. If you look at the picture on this slide, the likelihood of disease transmission increases as the tick's size or state of engorgement increases. If removed quickly and properly, the pathogens harbored by the tick will not infect the host. This is why some tick bites result in co-infections, while others do not result in disease at all. History will show that the importance of ticks has shifted from simply being a nuisance pest to becoming dangerous vectors of zoonotic pathogens. In the past, several tick-borne diseases were thought only to be of veterinary importance, but over time these organisms have proven to be pathogenic to humans. For example, anaplasmosis has been known to cause disease of veterinary importance since 1932, but it was not until around 1990 that it was identified as causing human disease. We know now that ticks carry a variety of pathogens. Some of these pathogens cause an assortment of diseases ranging from fatal infections like Rocky-Mounted spotted fever and ehrlichiosis to non-fatal infections like Master's disease. Furthermore, we can assume with near certainty that there are current veterinary pathogens that will ultimately be discovered as zoonotic tick-borne diseases. These 2011 maps indicate the distribution of reported cases of tick-borne diseases in the United States. In the top left, you can see that the majority of the spotted fever rickettsiosis cases are either in or surrounding Tennessee. Since 2010, all rickettsial infections, including Rocky-Mounted spotted fever, have been reported under the spotted fever rickettsiosis taxonomy. Similarly, the lower left Lyme disease map likely includes not only Lyme disease cases, but other cases with a Lyme-like presentation. Next, in the upper right portion of the slide, you will see that Tennessee also reported a large number of Ehrlichia schafiensis cases in 2011. Please note that this particular map does not include the Ehrlichia ewingi or undetermined ehrlichiosis cases. In the bottom right, you will see that Tennessee only reported a few cases of anaplasmosis. Lastly, you can see that the slightly different maps in the middle show that babesiosis and tularemia are rare in Tennessee. In synopsis, please note the similar rickettsial and Ehrlichia schafiensis distributions. Likewise, you can also see that anaplasmosis and Lyme disease cases also share a comparable distribution with high concentrations mostly in the northeastern U.S. For more information, please consult the source listed at the bottom of the slide. These next three maps indicate 2012 confirmed and probable cases of tick-borne diseases by county reported to the Tennessee Department of Health. Confirmed cases are those that are clinically compatible and laboratory confirmed, while probable cases are only laboratory supported. The exact difference between confirmed and supported lab results can be found by visiting the link at the bottom of the slide and selecting the desired disease. This site is set up very well and is very user-friendly. As for the distribution of spotted fever rickettsiosis, you will notice cases were reported in almost every county in Tennessee, with a high concentration in Middle Tennessee. The hotspots are displayed by the red and orange counties, which reported more than 20 cases in 2012. The counties in yellow represent those that experienced 11 to 17 cases in 2012, which still suggests a pretty high prevalence. In just a few slides, you will see that Tennessee experiences an extremely high incidence rate of spotted fever rickettsiosis when compared to the rest of the country. This map shows 2012 confirmed and probable cases of ehrlichiosis by county reported to the Tennessee Department of Health. Remember that ehrlichiosis cases include all those caused by Ehrlichia species, which includes Ehrlichia schaffiensis, Ehrlichia ewingii, and undetermined Ehrlichia species. The color key is the same for each of the 3 state maps, so you will quickly notice that there were fewer cases of ehrlichiosis than there were for spotted fever rickettsiosis in Tennessee for 2012. Again, Middle Tennessee reported the most cases, and a majority of the counties reported an ehrlichiosis case. The counties in blue reported 1 to 4 cases, while those in white did not report any cases. Tennessee exhibits a similar incidence of ehrlichiosis when compared to the rest of the nation. Something to keep in mind when viewing these maps is that data is dependent upon reporting to state health departments, which we all know is not always 100%. The last state map shows the confirmed and probable cases of Lyme disease in Tennessee for 2012. The case definition for Lyme disease is much more in-depth than the previously discussed tick-borne diseases. So again, please visit the site at the bottom of the slide for more information. Lyme disease cases require exposure to tick habitat in a Lyme endemic county, of which there are 0 in Tennessee. This makes travel history of paramount importance. This map makes it easy to see that there are not many Lyme disease cases reported in Tennessee. Again, the middle of the state has a high prevalence, but the northeastern portion also reported some cases, which was not the case with other tick-borne diseases in Tennessee. This is likely due to the fact that the majority of Lyme disease in the United States occurs in the Northeast. It only makes sense that the geographical range of not only the tick vectors, but also the infected wildlife host might spill into the northeastern portion of Tennessee. This general knowledge of tick behavior and the diseases they carry can provide healthcare providers some very valuable insight pertaining to tick-borne disease cases. Now that you have seen the national distribution of some tick-borne diseases, let's see how Tennessee compares. Unfortunately, Tennessee has a very high incidence of spotted fever rickettsiosis cases, which again includes Rocky Mountain spotted fever. Tennessee experiences 10 times more rickettsial cases per 100,000 population than the U.S. experiences as a whole. This is a very alarming statistic and one that should be given serious attention. The ehrlichiosis anaplasmosis figures here not only include all Ehrlichia species, schaffiensis, ewingii, and those unspecified, but these incidence rates also include anaplasmosis cases caused by Anaplasma phagocytophilum. Although this Tennessee incidence rate is much closer to the national rate, Tennessee still exceeds the U.S. in incidence of ehrlichiosis and anaplasmosis cases. Again, not where Tennessee wants to be. Lastly, Tennessee finally exhibits a lower incidence rate than the U.S. in Lyme disease incidence. In fact, Tennessee experiences an incidence rate that is 10 times less than the incidence rate of the United States. Since tick-borne diseases are vector-borne diseases, it is important that we take a little time to talk about the tick species that are of public health importance in Tennessee. The first tick species, and probably the most well-known, is Amblyomma americanum. which is better known as a Lone Star tick. The Lone Star tick is very important in Tennessee as it carries multiple pathogens that cause human disease. The most notable of which is Rickettsia rickettsii, the causative agent of Rocky Mountain spotted fever. Two other pathogens of equal importance are Ehrlichia schaffiensis and Ehrlichia ewingi, both of which are responsible for causing ehrlichiosis infections. Some other notable diseases carried by the Lone Star tick are tularemia and Master's disease. You may hear Master's disease referred to as Lyme-like disease or southern tick-associated rash illness, also known as star eye. It is important to note that Amblyomma americanum can harbor some other non-pathogenic rickettsia organisms. These organisms are of significance to Rocky Mountain spotted fever testing and to other healthcare professionals such as veterinarians. Not only does the Lone Star tick carry two of the most prevalent and most fatal pathogens in Tennessee, it is also one of the more abundant species in the state, making it extremely dangerous to Tennesseans. If you take a close look at the picture, you will notice that the adult female is the only life stage with the characteristic spot or lone star on its back. The larvae of this species are also well known as seed ticks. These newly hatched larval seed ticks are often responsible for infestations resulting in hundreds of individual bites on one person. As you can see in the distribution map, this species is located throughout the southeast and can be found in almost every county in Tennessee. The saliva of the Lone Star tick can cause mild skin irritation in the form of a dime-sized red area that appears within 48 hours of the bite. This reaction does not indicate disease transmission and should not be mistaken for other rashes related to tick-borne diseases. The next species of importance is Dermacentor variabilis, or the American dog tick. This species is also an important vector of Rickettsia rickettsii that contributes to human Rocky Mountain spotted fever infections. Furthermore, the American dog tick also has the potential to transmit Francisella tularensis, Rickettsia amblyommae, and Rickettsia montanensis. The latter two are both non-pathogenic organisms that are capable of causing false positive Rocky Mountain spotted fever test results. Current diagnostic testing lacks the specificity to differentiate in between the different Rickettsia pathogens. Due to this potential cross-reactivity, it is standard public health practice to refer to all Rickettsia infections as spotted fever rickettsiosis, as mentioned previously. The American dog tick is abundant throughout the central and eastern portions of the United States and is found throughout Tennessee. The adult members of this species are dark brown in appearance with random silver streaks on their backs. As with the Lone Star tick, the American dog tick is important because it can survive for long periods of time and it is responsible for transmitting Rocky Mountain spotted fever to humans. Although the potential for disease transmission exists, there are several factors that reduce the danger posed by the American dog tick. First of all, the Rickettsia rickettsii organisms themselves have lethal effects on the host they infect, which limits the population of wildlife reservoirs available as intermediate hosts. Furthermore, the tick itself uniquely produces rickettsiostatic proteins that attack the pathogenic organisms as a means of protecting the tick. Dermacentor variabilis' role as a vector of zoonotic pathogens is further minimized by the evidence that dogs are the primary host of the species and that the immature stages rarely attack humans. The next species of public health importance in our discussion is Ixodes scapularis. More commonly known as a black-legged or deer tick, this species is well known for the transmission of Borrelia burgdorferi, the pathogen that causes Lyme disease. The black-legged tick can transmit multiple other zoonotic pathogens while playing a pivotal role in the transmission of the most commonly reported tick-borne disease in the nation, Lyme disease. Besides Borrelia burgdorferi, hosts of this tick species can also be infected with Anaplasma phagocytophilum, which causes anaplasmosis. With a high potential for co-infection by these organisms and more, the black-legged tick is one species that you do not want to be bitten by. Since the black-legged tick is known for transmitting multiple pathogenic organisms, it is good news that it is scarcely present in Tennessee. As you know from previous slides, Lyme disease is very common in the United States, but not so much in Tennessee. Although there are small populations of this dark brown tick with its distinct black legs in Tennessee, we are fortunate that it does not have the same impact on us that it does in the Northeast. It is documented that the zoonotic pathogens harbored by the black-legged ticks in Tennessee are not as common as they are in other regions of the U.S. Scientists hypothesize that Lyme disease and anaplasmosis cases are rarely documented in Tennessee because the black-legged tick prefers non-human hosts in the South. Some favorite victims of this species are lizards, small mammals, birds, and white-tailed deer. It is believed that unlike the populations in the Northeast, Tennessee wildlife hosts rarely harbor the zoonotic pathogens that cause these diseases. Since the pathogen is not as widespread in these intermediate hosts, the frequency of a tick becoming infected during a blood meal is minimized. This break in the disease transmission cycle seems to be evident by the diminished tick-borne disease cases known to be caused by the black-legged tick in Tennessee. The last tick species of importance in Tennessee is Rhipicephalus sanguineus, or the brown dog tick. The brown dog tick commonly harbors Rickettsia rickettsii pathogens and is therefore a potential vector of Rocky-Mounted spotted fever in Tennessee. Although this tick is only known to transmit the one pathogenic organism, remember that that organism is responsible for the most fatal tick-borne disease in the state and in the nation. It is this potential and some of the species' unique characteristics that make it important to this One Health discussion of tick-borne diseases. The brown dog tick is unique to other species discussed because it has the ability to spend its entire life indoors. It is this characteristic that allows this dark reddish-brown species with no ornamentation on its back to be distributed throughout the entire United States. If an area becomes infested with brown dog ticks, it can be very concerning because it is responsible for transmitting Rocky-Mounted spotted fever in humans and in pets alike. Furthermore, infestations can be extremely difficult to resolve. Since this species prefers dogs to humans, and since it is scarce in Tennessee, it is of minimal importance as a vector. However, the brown dog tick can remain active year-round while it lives indoors. With that being said, the real danger exists when a family pet brings one of these parasites into the house due to the fact that females can lay thousands of eggs at once. Although uncommon, if this species were to lay eggs or molt into a new life stage inside a home, humans can very easily become the brown dog tick's next host. Now that you have a basic knowledge of the vectors that are responsible for transmitting tick-borne diseases, let's talk about the diseases themselves. The 4 tick-borne diseases of greatest importance to practitioners in Tennessee are Rocky-Mounted spotted fever, ehrlichiosis, Lyme disease, and Master's disease. So imagine with me, if you will, that it is late April and Tennesseans have been blessed with perfect springtime weather for the last several weeks. A 65-year-old woman seeks medical attention, complaining that all of a sudden she has a fever, is nauseous, and has muscle aches. Suspecting a tick-borne disease, the woman is admitted to the hospital and blood samples are required for serologic testing. 3 days later, before test results are complete, she is dead after quickly developing septic shock. Almost 2 weeks later, the serum test results returned positive for Rickettsia rickettsii IgM antibodies at a dilution of 1 to 256. After reporting the case to the local health department, the practitioner receives a follow-up call late in June and learns that only 1 case of Rocky-Mounted spotted fever was diagnosed at that hospital all of last year. Most alarmingly, he or she is told that there have been 2 or more positive Rickettsia rickettsii tests and just last week, an internist at the hospital reported a fourth case. The doctor decides it is time to refresh his or her knowledge of tick-borne diseases so that he or she can quickly recognize and treat any future cases. According to the CDC, as of January 1st, 2010, Rocky Mountain spotted fever cases are to be reported under a new category called spotted fever rickettsiosis. This change was made to better reflect the scope of cases being reported under the previous heading of Rocky Mountain spotted fever, as many of those cases were not identified as being specifically caused by Rickettsia rickettsii. As you might remember, under the spotted fever rickettsiosis taxonomy, Tennessee experiences incidence rates 10 times higher than that of the United States for this zoonotic disease group. This is frightening when you consider that 3 to 5% of reported Rocky Mountain spotted fever cases are fatal, and that up to 80% of untreated cases experience the same fate. You might also remember that the American dog tick is the most likely to transmit the causative agent of Rocky Mountain spotted fever, Rickettsia rickettsii. The majority of the cases, about 90%, occur in the summertime, with most of the patients residing in rural and suburban areas. Wintertime cases are also possible and can be extremely dangerous due to delayed or improper diagnosis. Rocky Mountain spotted fever patients experience a 7-day incubation period on average, and only 40% of them recall being bitten by a tick. Furthermore, most patients are either younger than 10 or over 40 years of age. One thing that almost all patients have in common is that either someone, including pets, or they themselves have been exposed to tick habitat, which includes wooded or grassy areas. This is why a thorough history is very important. Further confirmation of the importance of a thorough history is the statistic that less than 20% of cases present with the classic triad of symptoms, which include fever, rash, and a history of a tick bite. Most patients present with acute febrile illness that may or may not be accompanied by headache, myalgias, and GI symptoms. Note that the GI symptoms associated with the early stages of Rocky Mountain spotted fever can vary in severity from diarrhea to severe appendicitis-like abdominal pain. Most people that experience such persistent symptoms will seek medical help within a couple of days. This is good news, right? Well, not always, because patients will often seek medical care before the macular rash associated with Rocky Mountain spotted fever appears. This is typically 2 to 5 days after the onset of their fever. Early visits often result in delayed or misdiagnosis, which allows the rash to spread from its original location on the patient's extremities to more central locations on the body. If left untreated, the rash will develop into petechia after 6 or more days. This progression is a sign of serious infection and should be taken very seriously. Because remember, even 3 to 5% of treated cases can be fatal. Fevers of unknown origin during the tick season should stimulate careful questioning as to potential exposure to tick habitat, and as soon as Rocky Mountain spotted fever is suspected, diagnostic testing samples should be obtained and treatment should be initiated. Once there is reason to suspect a patient might be infected with Rickettsia rickettsii, again, diagnostic testing samples should be obtained and treatment therapy should be started. Since rapid, reliable confirmatory testing is currently unavailable, a common CBC and chemistry panel can provide relevant information. A CBC of a Rocky Mountain spotted fever patient often exhibits increased bands of white blood cells and thrombocytopenia, while a chemistry panel can indicate mildly elevated immunotransferases. 7 to 10 days post-onset, further laboratory confirmation of Rickettsia rickettsii antibodies can be obtained in the form of immunofluorescence assay titers. IFA testing demonstrates sensitivity well over 90% after 14 days, and a fourfold change from acute and convalescent samples is considered the gold standard for the diagnosis of Rocky Mountain spotted fever. Be aware that a negative acute test should not rule out diagnosis. Again, since we are looking for a fourfold change, that change can be from a zero or a lack of antibodies. What if the acute sample was obtained on day 5 of a patient's illness? Would there be any antibodies? Well, no, because it takes 7 to 10 days for them to develop. EIA testing cannot show this quantitative change in IgG titers that is needed for diagnosis. Other relative testing includes immunohistochemical staining of the organism and PCR testing. Please note that appropriate antibiotic treatment reduces PCR sensitivity. According to the CDC and the American Academy of Pediatrics, the gold standard treatment for this deadly tick-borne disease is doxycycline. In fact, doxycycline is the recommended treatment for all of the tick-borne diseases we will discuss and should be administered as soon as infection is suspected. To treat Rocky Mountain spotted fever, adults should be given 100 milligrams twice daily, and children under 100 pounds should be given 2.2 milligrams per kilogram twice daily. Despite common belief that doxycycline causes permanent staining of teeth, there is scientific evidence that has documented that there is no such risk that occurs at the recommended tick-borne disease dose and duration. Rocky Mountain spotted fever patients should be treated until 3 days after their fever subsides, with a minimum of 7 days of treatment. In cases where the patient is pregnant or hypersensitive to tetracyclines, chloramphenicol can be used as an alternative treatment. Treatment of Rocky Mountain spotted fever is most effective when initiated before day 5 of infection, and again should be initiated immediately once infection is suspected. Do not wait for the development of a rash or for laboratory confirmation to begin treatment. In May, a 40-year-old male visits his physician complaining of a headache, fever, sore throat, and vomiting. Although he is an outdoor construction worker, he does not recall being bitten by a tick, nor does he own a pet. His physician diagnoses him with pneumonia and initiates appropriate therapy. The patient experienced a persistent 103-degree Fahrenheit fever, and upon a sudden onset of confusion, he was taken to the ER. Upon examination, the doctor noticed diffuse erythema with several scabs on the 40-year-old's lower legs. A CBC indicated a slightly elevated white count with 3% lymphocytes and a decreased platelet count, while a chemistry panel indicated the following hepatic abnormalities: elevated AST, ALT, and alkaline phosphatase values. Antibody tests for Rocky Mountain spotted fever and ehrlichiosis causative agents were negative, so the patient was started on ceftriaxone and vancomycin. After the man developed seizures 6 hours later, acyclovir and doxycycline were added to the drug therapy. A convalescent serum sample obtained 31 days after initial presentation resulted in a Ehrlichia schafiensis IgG titer of 1 to 256. Up to 5% of the ticks in Tennessee are infected with an ehrlichiosis causative pathogen, making it the most prevalent pathogen in Tennessee. The high prevalence of Lone Star ticks in Tennessee may explain Ehrlichia's dominance. Although less fatal than Rocky Mountain spotted fever, ehrlichiosis still causes mortality in 2 to 3% of patients, making it a very important tick-borne disease. In the past, ehrlichiosis taxonomy included infections caused by Ehrlichia schafiensis, Ehrlichia ewingii, and Anaplasma phagocytophilum. However, recent taxonomic changes have labeled Anaplasma phagocytophilum infections as anaplasmosis instead of human granulocytic ehrlichiosis. The Tennessee Cumberland Plateau is documented as having one of the largest ehrlichiosis outbreaks. despite the fact that most cases occur in Missouri, Oklahoma, and Arkansas. Analogous to Rocky Mountain spotted fever, the majority of ehrlichiosis cases occur during the summer months from April through September and involve exposure to tick habitat. As a practitioner, one positive indicator of Ehrlichia cases is that almost 70% of patients report being bitten by a tick. Both males and females fall victim to this zoonotic pathogen, and those with compromised immune systems are at higher risk of a severe outcome. This disease is a perfect example of the importance of the One Health ideology mentioned at the beginning of this presentation. Because prior to 1986, ehrlichiosis was only considered to be of veterinary importance. I wonder how many other veterinary pathogens will be determined to be zoonotic in the next 20 years. Initial clinical presentation of human ehrlichiosis can range from a very mild to a severe life-threatening condition. Common clinical presentation is often sudden onset of influenza-like illness following outdoor activity. If you recall the Ehrlichia case presentation, patients can also experience malaise, vomiting, and even an altered mental state. The classic rash associated with ehrlichiosis can be very difficult to differentiate from that of Rocky Mountain spotted fever. The main difference is the region of the body on which it appears. 30% of children and 60% of adults experience an Ehrlichia-associated rash that appears on their torso. Furthermore, a rash caused by Ehrlichia infections is rarely observed on the palms and soles of the patient. Lastly, Rocky Mountain spotted fever rashes usually appear 2 to 5 days after onset of symptoms, while ehrlichiosis rashes develop later in the disease progression. Again, similar to Rocky Mountain spotted fever, this late developing rash can lead to delayed or misdiagnosis due to the promptness of a patient seeking care. Consistent with Rocky Mountain spotted fever in just about all tick-borne diseases, diagnosis and treatment of ehrlichiosis should be made based on a detailed history and clinical presentation, not on diagnostic testing. With that being said, a CBC and chemistry panel can again provide some helpful information. An ehrlichiosis patient's CBC will often reveal thrombocytopenia, leukopenia, and anemia, while a chemistry panel might reveal elevated aminotransferases. Besides some minor differences, ehrlichiosis sounds a lot like Rocky Mountain spotted fever, but do not worry because the confirmatory testing is exactly the same. Remember that the serologic IFA antibody testing is the gold standard, and we are looking for a 4-fold change in paired antibody titers. Since we need to quantitatively assess this change, reflexive titers must be requested from the lab. Furthermore, IFA testing is 100% sensitive to Ehrlichia antibodies 14 days after onset of symptoms. That is because antibodies are not detectable until 7 to 10 days out. I have discussed taxonomy quite a bit, but it is probably most important as it pertains to testing. Cross-reactivity is possible. Ehrlichia pathogens in general can cause a positive ehrlichiosis test the same way rickettsia pathogens in general can cause positive spotted fever rickettsiosis test. Lastly, remember that IHC staining of the organism and PCR testing can also offer diagnostic confirmation, but PCR sensitivity will decline with antibiotic treatment. Good news is that ehrlichiosis treatment is just as similar to the presentation and testing as of Rocky Mountain spotted fever. The gold standard treatment for ehrlichiosis and Rocky Mountain spotted fever are identical, which makes it nice since the two tick-borne diseases are nearly impossible to differentiate. The recommended treatment for ehrlichiosis is doxycycline. The dose and duration in both adults and children is the same as what we discussed with Rocky Mountain spotted fever. Remember that studies have proven that even 5 courses of doxycycline therapy in children before age 6 or 7 did not result in staining of their permanent teeth. The alternative treatment for ehrlichiosis patients that are pregnant or hypersensitive is rifampin. However, it should be used with caution as it is ineffective in treating Rocky Mountain spotted fever and has been known to lead to resistance. Treatment should be initiated within the first 5 days of illness or as soon as a tick-borne disease is suspected. Please note that fevers associated with Ehrlichia infections wane 24 to 72 hours after treatment, and if they do not, an alternative diagnosis should be considered. Late one July, a 2-year-old male Caucasian presented to his Tennessee pediatrician. He had a fever of 102.2 degrees Fahrenheit and a rash on his back. A thorough history revealed that the family owned 2 outside dogs, both of which had histories of tick infestations. Furthermore, the child's mother informed the pediatrician that she had removed a tick from the child's back a few days before the rash appeared. When asked where the tick was attached, the mother pointed to the center of the rash and stated that the tick was rather large in size. Laboratory analysis of the patient indicated an elevated erythrocyte sedimentation rate, and later ELISA results were found to be equivocal. Appropriately, the physician followed up with a Western blot assay for Borrelia burgdorferi, which confirmed a Lyme disease diagnosis when 6 bands were present. Made nationally reportable in 1991, Lyme disease is the most common vector-borne illness in the United States. Furthermore, this disease is very well known throughout the medical and general populations, despite evidence that most fatal cases are associated with complications or secondary infections. In fact, 95% of Lyme disease cases occur in just 13 states, all of which are part of endemic Northeast and Upper Midwest regions of the United States. Lyme disease is also reported as borreliosis, which includes other Lyme-like illnesses. Although it has not been proven to be caused by a Borrelia organism, Master's disease or southern tick-associated rash illness is thought to be included in Lyme disease surveillance cases. The seasonality of Lyme disease is from April to October, which is slightly longer than that of Rocky Mountain spotted fever and ehrlichiosis. Most Lyme disease patients are either younger, ages 5 to 9, or older, in their late 50s, and 50% of them are infected in June and July. Borrelia burgdorferi infections can take up to 30 days to incubate. This allows visitors of endemic areas time to return home before they become symptomatic, and also accounts for some of the non-endemic states that report Lyme disease. It is hypothesized that Master's disease could actually be responsible for some of the reported cases of Lyme disease in non-endemic areas. However, this cannot be proven because the pathogen responsible for causing Master's disease has yet to be isolated in the laboratory. Furthermore, we know that black-legged ticks are present in Tennessee, making Lyme disease a possibility. Lyme disease patients seek medical attention on average 7 to 10 days after being bitten by a black-legged tick. These individuals don't always exhibit a fever, but instead often present with what is sometimes called the summer flu. This includes headache, malaise, myalgia, arthralgia. Unlike Rocky Mountain spotted fever and ehrlichiosis, up to 80% of Lyme disease cases present with classic erythema migrans, or bullseye rash. As you will see in the next slide, the central clearing characteristic of the EM causing the bullseye appearance is not always present. The rash associated with Lyme disease often originates from the bite site and expands outward to a diameter greater than 5 centimeters. In the early disseminated phase of the disease, 50% of patients will display multiple EM lesions, which can appear anywhere on the human body. Patients can also experience a variety of symptoms during this phase, which can range from transient migratory arthritis to fatigue to cardiac and neurologic symptoms, which include but are not limited to myocarditis and meningitis, respectively. In the next late disseminated phase of Lyme disease, 60% of untreated patients experience Lyme arthritis. Furthermore, 20% of post-treatment Lyme disease syndrome patients can experience these symptoms recurrently. Healthcare providers suspect possible autoimmune disease involvement in these patients because they have been found to be non-responsive to antibiotic therapy. As I mentioned in the previous slide, you can see that erythema migrans associated with Lyme disease can be present anywhere on the human body. You will also see in the top left picture that multiple EMs are possible. These pictures show how varied the bullseye lesion can be. If you look closely at the middle picture of the rash on the upper portion of the chest, you can almost make out a ring about an inch or so around the outside of the patient's scab. It is somewhat difficult to see, but remember this picture when we talk about the rash associated with Master's disease. The last thing that I want to point out in these pictures is the size of the EMs. Remember that they start at the bite site and expand outward to a size greater than 5 centimeters in diameter. As with any tick-borne disease, diagnosis should be based off of a detailed history and the patient's clinical presentation. With that being said, blood work is always a good idea. 50% of Lyme disease patients experience an elevated erythrocyte sedimentation rate, while only 30% will display mildly elevated hepatic transaminases. Also worthy of notation is that less than 10% of Lyme disease cases display hematuria or proteinuria upon blood analysis. The confirmatory testing for Lyme disease is a two-step process, and both tests are plagued with false positives. The first step in confirmation is an ELISA test. Only if the results of this test are positive or equivocal should the second test, a Western blot, be performed. Positive Western blot assays are determined by the presence of 2 or more IgM bands or 5 or more IgG bands. I must tell you that according to the CDC's Nationally Notifiable Disease Surveillance System, there are multiple criteria in which a Lyme disease case can be confirmed. The most relaxed definition, usually used in the Northeast and Upper Midwest, is the presence of EM with known exposure. Exposure does not require tick bite history, but simply contact with tick habitat in a Lyme disease endemic county within 30 days of EM development. But since no Tennessee counties are endemic for Lyme disease, this confirmatory definition does not apply and should not be used. Instead, this two-step approach should be adhered to. The alternative treatments for Lyme disease differ from those associated with other tick-borne diseases, but the recommended treatment is still doxycycline for adults and children. Lyme disease therapy should persist for 14 to 21 days and should be based on clinical manifestations and disease stage. 2 other treatments for Lyme disease are cefuroxime acetyl and amoxicillin. Furthermore, macrolides can be used as an alternative treatment, but you should be aware that it is less effective and can result in relapse. Although it would be difficult to confuse Lyme disease with some of the other tick-borne diseases we talked about, doxycycline effectively treats all of the discussed infections. The last disease we are going to discuss is Master's disease, or star eye. which stands for Southern Tick-associated rash illness. There are a lot of mysteries about this Lyme-like illness. So much is unknown about Master's disease because it is not reportable to state health departments or the CDC. Scientists suspect that the Lone Star tick is responsible for causing Master's disease, but have been unable to prove such due to multiple failed attempts to isolate a pathogen in the lab. However, scientists have also struggled to consistently isolate Borrelia burgdorferi in black-legged ticks residing in the South. Furthermore, most of these Lyme disease or Lyme-like cases that are seen in the South do not follow the classic Lyme disease progression. So what do we know? It is known that Master's disease cases are most prevalent throughout the southern U.S. and tend to occur in the summer months just like other tick-borne diseases. Peak activity similarly occurs during June and July. Master's disease is believed to have a 6 to 9 day incubation period and is not known to be fatal. Although extremely similar and nearly impossible to differentiate, there are some subtle differences between Master's disease and Lyme disease. Patients with Master's disease can often present with only a rash, but they can also have symptoms of fatigue, headache, stiff neck, myalgia, and joint pain. As you will recall, these symptoms are also common with Lyme disease patients. However, patients with Master's disease are more likely to remember being bitten by a tick. The rash associated with Master's disease is nearly identical to the erythema migrans associated with Lyme disease, but there can be some small differences. It is believed that the EM contributed to Master's disease appears faster and is smaller, 6 to 10 centimeters, than the 6 to 28 centimeter EM associated with Lyme disease. Patients with Master's disease rarely experience multiple EM lesions, whereas 50% of Lyme disease patients experience multiple EM lesions. Lastly, you will see on the next slide that central clearing of the rash appears to be more common with Master's disease cases. Here are several pictures of erythema migrans that were documented not to be caused by Borrelia burgdorferi. You will notice that each patient has only a single EM that appears to be much smaller in size than the Lyme disease EM pictures we viewed earlier. Now take a closer look. Nearly all of these EMs, with the exception of photo D, look exactly like a bullseye, don't they? Master's disease EMs tend to have a more central clearing. Due to the countless possible EM presentations, it is extremely difficult to differentiate between the signs and symptoms associated with Master's disease and Lyme disease. This makes treatment rather straightforward, though. You guessed it, Master's disease diagnosis should be made based on a detailed history and clinical presentation. With this disease, you don't have much of an option since the causative agent has yet to be identified. There is not a confirmatory laboratory test available. One indication of Master's disease might be the lack of plasma cells in a biopsy. The tick biology that we discussed earlier might also come into play. If it is possible, identification of the tick species can help offer some diagnostic information. Since we know the black-legged tick is responsible for transmitting Lyme disease, and we are fairly certain that the Lone Star tick is the vector responsible for Master's disease cases. Depending on the geographic location, it is sometimes better to observe these cases due to the increased risk of serious reactions and costs associated with treatment. In the southeastern U.S., it is recommended that patients without travel history that present with an EM rash are simply observed. In the mid-Atlantic states, patients should be treated the same way a Lyme disease case would be treated. Just a quick review since we have covered a lot of material. Tennessee experiences an incidence rate of spotted fever rickettsiosis, which includes Rocky Mountain spotted fever, that is 10 times higher than the U.S., and a Lyme disease incidence rate that is 10 times lower than the U.S. per 100,000 population. Although this is not Texas, the Lone Star tick is the most abundant species in Tennessee. Equally as important is the number one most prevalent pathogen in Tennessee, Ehrlichia. Remember that 90% of tick-borne disease cases occur from April to September. During these summer months, be aware of the classic tick-borne disease symptoms: sudden onset of fever or headache, accompanied by malaise or myalgia. Do not rely on the presence of a rash, since up to 30% of Ehrlichia and Rocky Mountain spotted fever cases will not have one. Never wait for a rash to develop to begin treatment. Recollection of a tick bite is rare. Do not count on it for a diagnosis. As for early laboratory indicators of Rocky Mountain spotted fever and ehrlichiosis, look for elevated aminotransferases and thrombocytopenia. Remember that it is imperative that you start your treatment prior to receiving diagnostic results. If the detailed history and clinical presentation indicates tick-borne disease, doxycycline is your one-stop shop for both adults and children. Lastly, confirm the case with IFA testing after day 14 of illness, when the test is well above 90% sensitive to the newly formed antibodies. As we have discussed under the One Health ideology, zoonotic tick-borne diseases are ever-changing. This slide contains a few recent developments regarding tick-borne diseases. First, the Gulf Coast tick, Amblyomma maculatum, has been documented to harbor Rickettsia parkeri. This recently pathogenic organism was documented in West Virginia in 2002. It causes a classic febrile presentation, including a rash, but it also causes eschars. Fortunately, doxycycline treatment has been found to be effective. A new flebavirus was documented in Missouri in 2009 and is called Heartland virus. Amblyomma americanum has shown to harbor this organism, which was recently documented in western Tennessee as well. Patients again present with a classic tick-borne disease symptoms of fever, headache, myalgia, and nausea. Some laboratory testing is available to identify this virus. Lastly, black-legged ticks have been found to harbor Borrelia miyamotoi, which is a spirochete that causes a new relapsing fever. Infections have been shown to cause progressive mental deterioration with or without classic Lyme symptoms. Unfortunately, there are no diagnostic or treatment protocols for this illness. This module would not be complete without a quick mention of prevention and patient education. Currently, there are no vaccinations available for tick-borne diseases, and prophylaxis is not recommended. Ultimately, we know that prevention and patient education are our best methods for minimizing tick-borne diseases. If a patient comes in to see you for anything, and you know they are at high risk, discuss and encourage tick bite prevention. Spray before you play. This includes chemical barriers for both humans and pets. That means DEET for humans and year-round monthly preventatives for pets in Tennessee. Don't forget to treat the yard as well. Next to prevention, the most important thing to stress is tick checks. Remember, ticks have to be attached for hours to transmit pathogens. If a tick is found, encourage patients to properly remove the tick. Remind them to do this with pointed tweezers and not with folk remedies like hot items or chemicals. Once the tick is properly removed, encourage patients to preserve the tick for several weeks or about 30 days. Simply observe asymptomatic patients and tell them to seek care if they develop rash, fever, headache, malaise, myalgia, etc. At that time, they can have the tick identified or tested for pathogens. I have to give an extra special thanks to Dr. Lorinda Sheeler at South College. She was absolutely pivotal in the preparation and delivery of this material. Next, Vanessa Ross in the CME department at Des Moines University for walking me through the CME accreditation process and sponsoring me along with the Iowa Medical Society. Should you be interested in any further information, please utilize the additional resources listed or contact DMU or myself via the information provided at the end of the module. Also, please visit the websites listed here. They are all unbelievable resources that are very user-friendly. I hope you enjoyed the presentation.